First of all, a disclosure, Gasman and MedMan Simulations are a nonprofit corporation. I derive no benefit from it. I did write Gasman many years ago and still managed to support it and keep people using it. Optimal anesthetic volatile agent delivery requires the things we just heard a moment ago: quickly, precisely, accurately, and persistently. We could use an electrical model to describe inhaled anesthetic moving around the body, but this audience probably could use this, but no one else could. Our industrial colleagues have used feedback control to overcome this complexity for users. Possible in the United States soon, recently discussed at an FDA summit just 3 days ago that I attended on behalf of the ASA. It is probably going to come to the U.S. These are the devices that you've seen before in this meeting, available in your countries and not in mine. We and clinical colleagues might use Gasman to understand the kinetics of these inhaled drugs. And Gasman is a physiologically-based model based on Keddy's work in 1950, and we're not going to go through any of this, but it will be available. Gasman solves the simultaneous differential equations using Euler's method, the simple approach, which we then replaced with an exponential component many years ago in order to make it stable from mice to elephants for cardiac outputs under 100 liters per minute, just so that we as teachers in this field can simulate things to understand the great extent of possibilities when we want to understand a model. Many in this room are Gasman users. Raise your hand if you use Gasman at the present time. Raise your hands high. Great. Those of you whom I've not given a button to, a Gasman button, come get one from me. Wear it so that you can talk to each other about your use and try to sit with me at lunch to discuss how you can use it better in your work. We believe Gasman is correct. Over here we see that Bouillon and Schaefer demonstrated that many years ago. It seems to be appropriate for the generalized patient. It does go, as I mentioned, from mice to elephants, so size is a dramatic thing it can do. Gasman model is a structure-behavior model. It shows you the structure and superimposes the model, superimposes the model's behavior. The agent level expressed in partial pressure is across the top, and the flow of the carrier and agent is across the bottom, so that what we have is anesthetic going from the delivered to the inspired, to the alveolar, to the arterial, to the vessel-rich group, which is the brain in our minds, to muscle and fat, and finally into venous blood, from which it then returns to the alveolar gas in the mixed venous blood and can appear as inspired when our fresh gas flow is very low, or be totally thrown away when our fresh gas flow is very high. We have, again, the linkage between compartments. This was designed to show physically what the mental model is supposed to create. That's what this was built for. The time, the uptake, and the delivered quantities of anesthetic are in the bottom right-hand corner. Our goal is typically 1 MAC or some fraction or multiple of 1 MAC in the vessel-rich group right over here. Not shown in this picture because I erased it to make this a simple diagram. I've erased the picture of the syringe right here, which Gasman has, which one can use to inject liquid into the breathing circuit. You can see it, by the way, in a big display in the conference room in between lectures. A graph will trace the behavior over time of the alveolar response to a step change in delivered concentration from an open or non-rebreathing circuit. That is, inspired is up to 1 reference level, and this would be the alveolar concentration of isoflurane, sevoflurane, desflurane, and xenon, which we will hear about later today. They all have the same general shape, but all have different plateau heights as we teach it. The alveolar and other tissue response to a step change in delivered concentration with a high fresh gas flow and a low fresh gas flow is what I want to look at for a moment. That is, I will use a fresh gas flow of, I will use a vaporizer setting rather of 9% desflurane in each situation here. I will then use a fresh gas flow of 8 liters a minute in one example and 1 liter per minute in the other example. As you will discover in your institutions when you try to install Gasman, if your IT people don't let you have control of installing applications, you'll have to show pictures of it, as I will now. That's why we're not doing this in real time and live. So we've got the 8 liter versus the 1 liter per minute, and here we're going to see the two of those. We have the high flow and the low flow, and we are reading this overlay screen as show circuit, or inspired, over delivered. Show the inspired divided by the delivered concentration on a point-by-point overlay in the first 15 minutes. Clearly, when we've got a high fresh gas flow, inspired gets to where we want it. When we have a low fresh gas flow, well, we picked that because we wanted that concentration. We were smart enough to do it on purpose. But if we weren't thinking, we would get this, unfortunately, incorrect answer. When we look at the alveolar over the delivered concentration, it's pretty much close to that which is in the inspired gas. And then if we look at the vessel-rich group compared to the delivered, again, the brain is very sluggish, very slow in this anesthetic. Now, if we think about it, the drug is the same drug. So if we look at the alveolar concentration divided by the circuit concentration, they have almost the same relationship because it's the same drug. And in fact, the vessel-rich group compared to the alveolar gas, again, they are identical. We've never changed the drug when we have changed the fresh gas flow. As long as we can control the inspired and expired concentration, we as good clinicians can give good anesthesia. Well, pretty good anesthesia, not as good as the designed systems that do this for us. So low fresh gas flow makes inspired track delivered very poorly. But if the inspired is well controlled despite the low fresh gas flow, the other compartments will still be well controlled. We can give a good manual anesthetic with low fresh gas flow. Now the curves here were not identical because I'm using ratios of concentration. A smart, good engineer would be computing in the real-time basis the inverse system transfer function between these things. Eager from day one had the expired divided by inspired. We have all done that through our careers. We know that the mathematics doesn't explain everything perfectly, but it's good enough for clinical work. Now, some of today's and most of tomorrow's anesthesia machines achieve agent control, and they do it by using the feedback control of the measured expired agent. Let's look at a couple of examples where my skills in my operating room and that of my colleagues didn't do as well as we would like to when we were using low fresh gas flow. I had a well-anesthetized patient on a desflurane oxygen air anesthetic, drifted a little bit too deep over time, and what I wanted to try to do is get this patient a little bit lighter. I figured what I should do is I should turn off the vaporizer for a little while, look at inspired and expired to fall where I want it, and then hold it at that lower vaporizer setting, and then do these little incremental steps downward, or rather decremental steps downward. Rather than just turning the vaporizer down or off, I wanted to do this more deftly, sort of the way my feedback controlled automated anesthesia machine would do if I in fact had it in my operating room. The best that I could do is the following. I'm going to zoom in on this. This is a GE remote view of what was going on in this room at the time. I just want us to focus on the desflurane concentration. We're looking at inspired and expired on a point-by-point basis here. The anesthetic had gone higher than I wanted it to be. I turned the vaporizer off. I turned the fresh gas flow up to 8 liters a minute, and I brought the inspired and expired, in fact, down nicely over the next few breaths. And then I turned the vaporizer down by 1% from where it had been before, and it drifted up again. And I did the same thing again. I turned it off until Untitled got to where I wanted to, and I turned the vaporizer back up to 1% less than it was before. And again it came back, and it came back, and it came back again. I couldn't, no matter how deft I was with my hand on my vaporizer and my fresh gas flow, quickly get my patient's steps to be lighter. Now, if all I wanted to do was wake the patient up, I could turn the vaporizer off and the fresh gas flow way up. But we only get to do that once per patient. Lowering the anesthetic concentration, we often get to do many times per patient. Here's what that looked like when I simulated it afterward with my resident with GasMan. exactly what we had done. We had the fresh gas flow high. We had run the fresh gas flow low. Several times we tried to get the anesthetic level down, and it would bounce back up again each time. Very easy to simulate exactly what we had seen so that we could go back and say, well, how long should we have had the vaporizer off? Should we have done it for a minute longer? What would have been the right way to manage this reduction of anesthetic depth? That's what interactive computer models can do for you. They can allow you to simply use the model to test the hypotheses and over again try your hand at it, each time saving the simulation, changing a little bit until you finally say, I'm going to do that tomorrow in the operating room. I can get that better. I'm going to give you another example of where low flow got us in trouble recently. This is an American hospital. Our fresh gas flow was 1 liter per minute. The Sevoflurane vaporizer was set to 10%, and the inspired and expired were 7/6%. It was a perfect anesthetic. Everything was going fine until this patient was slid into the CAT scanner. And at that point, a tear occurred in the breathing circuit where I've drawn that tear over here. When that happened, the clinician who was there simply turned the fresh gas flow up because all of a sudden his bellows or piston was totally empty and there was no choice but to turn up the fresh gas flow. But without turning down the vaporizer, this was what we saw. Here is inspired going up and expired going up and blood pressure going down, and with some pressors and things of that sort, everything get back to normal. We can get into trouble with low fresh gas flow if we're doing it by hand and we don't recognize that if a leak occurs suddenly, we must respond to that by two actions at the same time. Fresh gas flow cannot go up. The vaporizer has to come down, and then fresh gas flow can go up. Here's simulating exactly that same thing in GasMan. We looked at it afterward and said, this is totally predictable. The fresh gas flow was running nice and low and everything was perfect. And right over here is when that circuit broke and the anesthesiologist turned up the fresh gas flow and the inspired, the expired, and the vessel-rich group all got much deeper. He recognized what was going on, immediately at that point turned off the vaporizer, left the fresh gas flow high, brought down the inspired, expired, and vessel-rich group, and then allowed everything to stabilize over the next few minutes. So this is what a model can let you do as long as the model is easy enough to use. We've heard all of the brilliant models created by my colleagues, all of which are spectacular in research, but to try to get your hand on this, probably this is an easier way to do that. Let's talk about wake up. No, we're all awake. But wake up is the inverse of induction. And after an infinite length anesthetic, the curves for wake up are identical to the induction curves, but flipped upside down. When the anesthetic is shorter than of infinite length, then the wake ups are a little bit faster, but not very much faster. Inhaled anesthetics are unique in that the entire cardiac output that is passing through the lungs is the clearance physiological organ, unlike liver and kidney that do things slowly. Yes, we still have redistribution of drug, but we also have 100% of cardiac output helping to clear drugs according to their inversely proportional to their solubility is the clearance rate. I want to talk for a moment about the brain delay after an end tidal change. We've heard that a couple of times this morning. It's 2 to 6 minutes for all anesthetic agents, even the intravenous ones, and this is essentially the effect site delay. It's the way to think about it. It's crucially important when we use an agent monitor to not believe that the agent monitor now is the patient's depth of anesthesia now. What's on the agent monitor now will be in the patient's brain in about 3 minutes. If we use the anesthetic agent trend graph, we can look at that and understand what is going on. If you don't know how to push the buttons on your agent monitor, let you look at a short-term graph, learn how. Play with the buttons. Most anesthesiologists, in my experience, do not know how to get that graph up on their screen. But if you've got that graph up there, and here we've got an example of the GE solar monitor, an older monitor. At time 0 here, inspired goes to 0. Expired is coming down. The vessel-rich group has gotten to the expired has gotten to 2% desflurane, which is in fact to 1/3 of the 6%, so that's the MAC awake. And 3 minutes later is when the patient begins to have the BIS suddenly start coming up, and everything fits the model perfectly. It takes about 3 minutes, and if you think it's going to happen earlier, don't even think for a moment it's going to happen earlier. It's going to happen there. It may not always be 3, it could be 2.5, and it could be 5. And of course, if you have other drugs superimposed, providing fractional MACs of their own, this MAC effect is at least additive, possibly synergistic, as we've heard today, but in general, mostly additive, and therefore it will make a difference. You simply don't have to get the patient down to 0.33 inhalant MAC. You might have to get the patient down to 0.3 or 0.25 inhalant MAC. This is, again, a simulation in GasMan of that same thing, with the sevoflurane delay here is 3 minutes at the end. I've zoomed in on that. Here, it's a 1.5-hour anesthetic. Fresh gas flow was high. Vaporizer setting went to 0, the delivered concentration. The inspired fell, the expired fell. The vessel-rich group has come down, and it has reached MAC awake 3 minutes after alveolar reached it. Notice, by the way, in this case, after only 1.5 hours of anesthesia, the level of anesthetic in the patient's muscle is 50% of 1 MAC. Muscle is the thing that causes the late re-anesthetization if one extubates and the patient becomes apneic. We published that in Anesthesia and Analgesia last month with GasMan models explaining that very clearly. Muscle is the source. Notice that fat anesthetic level has built up to almost nothing in this time, and in fact will never build up to anything significant in your patients during your anesthetics. Here's what it looks like if you superimpose a sevoflurane anesthetic graph over a GasMan model of it. It's pretty close. Is it perfect? Is this model absolutely right on the money? No. Is it close enough for any kind of work we might want to do? Yes, it really is. So, number one, anyone can download GasMan Student Edition free from anywhere in the world. It is totally free. Attendees here can download a 2-month GasMan full license. The difference between the student version and the professional version is student version doesn't let you save simulations. That's it. If you really want to use it in your department for teaching, help support the nonprofit corporation by actually buying it. And if not, create simulations which you can share across the universe. That is, a GasMan simulation can be played back by anyone, anywhere with that student edition. So it really becomes a universal tool for us understanding this very, very complex and yet simplifiable field of inhalation anesthesia kinetics. Thank you.